So firstly, we have a poll that we would like you all to participate in. And the question is, what percentage of the public do you feel suffer from dentine hypersensitivity? So please vote now. We're going to now move on to our first panelist, Dr. David Gillam. So the overriding arch of why we do what we do as dental professionals is to improve quality of life. And we certainly do not wish to have a negative impact on their quality of life. We know periodontal treatment and lifestyle, etc., can cause dentine hypersensitivity. So thinking about dentine hypersensitivity in the broadest sense of the patient's perspective, it's largely understood that 30 to 40% of the public suffer from dentine hypersensitivity. But according to our results today, the poll states, each one of you who voted, that maybe you think that 60% of the public suffer from dentine hypersensitivity. So, David, what do you believe is the biggest challenging in managing dentine hypersensitivity from the clinician's perspective first?
Thank you, Victoria. Good evening, everyone. Just looking at that poll, it does reflect what some of the studies show, and it will depend on whether we get the information from the clinical perspective or from questionnaires. One of the best studies I've seen on a questionnaire was in 1995 by Dutch colleagues, where they said 1 in 10% of individuals suffer from dentine hypersensitivity. And that's been borne out by various recent reviews. But the problem is that I think it depends where you get your information from. So if you're in a clinical environment in general dental practice, you will actually get a lower percentage of your patients having sensitivity. I think one of the problems is that generally it's the patient who offers the information that they have a problem. So that means if the dentist or clinician doesn't ask the question, then they're not going to get the answer. So I think that's first and foremost very important that clinicians diagnose the problem by asking questions, but also listening to the patient. And I think if we do that, it will help. Now, one of the problems for clinicians is that a lot of clinicians feel that dentine hypersensitivity is a nuisance problem. Generally speaking, it's transient. It relies on code mainly. And also I think most patients will not even attend the dentist because they think it's quite low risk. Compared to toothache and appearance worries, I think sensitivity is probably about the third most common reason why people come to see the dentist. So I hope that sets the scene to your first question.
Yeah, thank you, David. And what do you think is the biggest challenge in managing dentine hypersensitivity from the patient's perspective?
Well, again, I think you alluded to this when you started about the problem with COVID. There are many obstacles or barriers to dental care. And if you look at a lot of the records and research, you're talking about 50% of the patients do not attend a dentist for various reasons. As I alluded to, very often, because a number of people think sensitivity is quite mild in nature, they often self-treat and don't attend a dental practice. What I think we have to be aware of is that it does have an impact on the quality of life. Now, when we have done previous questionnaire studies with dentists, most dentists seem to think it's a mild to moderate, and they put it quite low down in their list of priorities. And I think also they find it very difficult to diagnose the problem. When we asked hygienists to do it, they had a better understanding of the impact on the quality of life. I think the quality of life actually of patients is underrated. More recently, people from Sheffield and Bristol have done some very good work on quality of life issues, but in the past, it has been poor. And when I used to do the questionnaires and clinical studies, we simply asked patients about 4 questions about what affects them on their day-to-day living. And in that way, you can get an idea of what they are concerned about. The one thing which often is forgotten, if you give a patient cold water when you ask them to rinse out, they may get sensitivity. And I'm not suggesting that you use that as a diagnostic tool.
No. And what do you feel the real impact then is? You mentioned about quality of life, but quality of life is from dentine hypersensitivity.
I think there is an impact. As I said, most clinicians view it as mild to moderate. Most patients, I think, can cope. We all have stories of patients who will tell you that they have a sensitive tooth and they will drink on the other side of their mouth. One study which actually suggested that patients will not, as I say, not attend a dentist, but they will use various products, toothpaste products, to treat themselves. I think you've got the slide up there. Basically, we rely on open tubules and fluid dynamics. In order to have open tubules, you have to have tooth surface loss or recession. So going to the dentist may actually impact on this. When we scale and debride, we may actually be causing some damage over time. Patients using acidic drinks, brushing following drinking, these type of things may also have an impact on the quality of life.
Yeah. You have an extensive background in dentine hypersensitivity. How did you get involved with Robert Hill to overcome the problems of dentine hypersensitivity?
Okay, well, historically, I've worked in a number of places in university and industry. I came to Queen Mary in 2009, and a chance meeting internally with, I think it was after a dental fair, and we started chatting, and that went on for an hour and a half, and we found that we had a lot in common. I had a background of clinical testing, and also I was initially involved in the original BioGlass toothpaste, but before that, as a periodontist, I was using PerioGlass. Some of those who are older might be aware PerioGlass was a bioactive glass which was used for a bone filler, and I noticed there that the particle size were very small. So I started experimenting with it, and on the basis of my experiments and work through projects at the Eastman Dental Hospital in London, we were put in contact with the original company that developed bioactive glass toothpaste, which was without fluoride at that time, and that became Novamin, and then that was obviously sold on to GSK. But through postgraduate projects, Robert and I have developed the bioactive glasses, and so Robert's got an extensive knowledge of dental materials and also bioactive glass in particular. So between us, and I have to say, thanks to our undergraduate and postgraduate students, we amassed a lot of research, but mainly in the laboratory. we were fortunate when we initiated the company with Richard Watley. We then were in contact with people who could formulate the toothpaste and develop that way. So I think what I have to say, one man or one woman or doesn't resolve these type of problems. It requires a team, and we are very grateful for all those who collaborate with us in the development. And from a clinical perspective, what I've enjoyed is that working with Robert is that we thought of a concept, and we were able to develop that into an actual fact. So I often say we went from concept to consumer. And as a clinician, one who's worked in research and also in industry, it's quite fulfilling to actually have a product which we've developed that is actually out and helping patients. As most of you will know, a lot of products never ever get out of the research phase, and they're never seen in the clinical environment. So I think about 5% of all research actually is successful, which is quite challenging.
Yeah, thank you. What would you say are the top 5 considerations when managing dentine hypersensitivity?
Well, I would suggest that both from the patient and the clinician, there's education for the dentist, that they need to be aware of how to diagnose the problem, when to monitor it and treat it, and to be sensible when you treat it. If someone has mild to moderate generalized sensitivity, for example, you can use an over-the-counter toothpaste, which would be perfectly suitable. If it's localized and severe, you may need to use more invasive materials. You can use a varnish, for example, and it may end up leading with lace ionomer or so on. So from the dentist, it's important that they manage it and monitor it. And there must be, I would suggest, a feedback loop that if your initial diagnosis or your differential diagnosis is wrong, or your treatment doesn't work, you need a way back to re-diagnose at that time. I know it's difficult in practice to actually spend a lot of time monitoring, but there are ways of monitoring within your time frame. So it's important from a clinician to have that management strategy. For the patient, from the educational point of view, we need to change behavior. We need to get them to take ownership of their own mouth, and that would mean, for example, looking at diet, looking at brushing habits. For example, if they have a problem, if you see that they have a problem as a clinician, that they are brushing incorrectly or causing them damage, then I would suggest you can change that and get them to modify their technique. So I think from an educational point of view, that's very key. There are simple ways of diagnosing the problem. If you have a patient who comes in, for example, the diagnostic challenge is that we have a range of clinical conditions which have similar symptoms, but generally speaking, if you blow cold air on the tooth in question or teeth, you will get an initial response, and that pain or discomfort should go. If it's persistent, then I think you need to look at something else. A simple way of doing that is asking the patient to rate the pain following the cold air on a 1 to 10 scale or a verbal scale, and then you can assess it that way. A simple tip which you can use, you could check the score of the tooth to start with, and then apply a varnish or toothpaste or desensitizing paste, and then after a few minutes try again. And if there's no pain or it's resolved, then you may be reasonably assured that the problem is dentine sensitivity. What I would say, the challenge is that it's very easy for clinicians to just give a tube of toothpaste or polish the teeth and send the patient away. That in itself is of no use if you don't change the problems that cause sensitivity in the first place. So if there's any etiological or predisposing features which have caused the sensitivity, then you need to resolve these. As I say, it's simply not good enough to actually send them away because you're busy with a toothpaste. So I think educationally, both from the clinician's point of view and also from the dentist's point of view, with quality of life, again, I think the patients will need to know what's causing their discomfort and trying to work around their diet, for example. For example, if you are a cyclist, you are going to use a lot of high sugared products throughout your cycling, and that could have an impact on sensitivity. And obviously, if you do it over a long period of time, as we know from some other surveys of that, high proficient athletes, their dental caries rate is poor. I think what I would also suggest, if I may, is that there's a tendency to treat each patient in general. And what I would say that it's important to realize that there's no such thing as one glove fits all. Every patient is an individual. They have individual needs. They have individual concerns. I think it's important within the scope of our practice to recognize that. And it may well be that there may be a number of products that you might have to use in combination over the counter with in-office or professionally applied products to help. So the challenge is don't concentrate on one and think that that is going to be the panacea for all treatments. So I think that's very important. The preventive aspects of dentistry is very key here, and it's a package, but please remember that patients are individual. I think I will start with one more, is that does the dentist have the confidence to treat dentine sensitivity? And studies have shown throughout the world that most dentists and clinicians appear not to have confidence. So I think webinars like this, where we can distribute up-to-date information and give practical tips, may help clinicians gain confidence in the treatment and management of dentine hypersensitivity. So I hope that helps.